Hola, hola. 1, 2, probando, probando. 1, 2, 1, 2, probando imagen y sonido. Esta cámara enfoca acá, lo que serían estas dos sillas, para que si hay gente del otro lado. Ahora tengo muteado el micrófono y la cámara por las dudas, si no querías que se vea.
¿Cómo es esto? Sí, habilita.
No, hablan solo por acá, así los escuchan bien claro del otro lado.
Bueno.
Ya están activados los subtítulos. Y lo único era recordarle a las personas que están afuera. Sí, yo voy a estar acá, pero yo para que le puedas explicar a las otras personas lo de los subtítulos. Ah, sí.
Dans ma tête, ça peut aller, puis en fait, quand je veux parler, ben ça.
Estamos traduciendo. Bueno, buenos días, Juliet. Buenos días.
No digamos nada.
No digamos nada.
Arturo.
No escucho. Arturo. ¿Se escucha?
Let's not say anything, listen to it.
Ahí
Sí.
se escucha. ¿Ok? Voy a hablar por el micrófono. Si se escucha, levanten el pulgar. ¿Ahí se escucha bien? ¿Sí? Ok. Bueno, no sé si querés asomarte acá. Les quiero comentar lo siguiente. Nosotros estamos transmitiendo por el canal de YouTube de la Universidad ISALUD. O sea que los participantes y los alumnos y los profesores van a estar conectados a través del YouTube. Cuando haya detrás mío está el vicerrector de planificación, el doctor Alejandro Costa, y la coordinadora de la maestría de Economía y Gestión. Con ambos trabajamos hace 15 años. Calculamos que va a haber entre 50 y 60 alumnos y profesores escuchando estas conferencias. Así que venimos con algo de retraso. Yo no quiero extenderme mucho, pero en principio nuestro profundo agradecimiento a la Escuela de Altos Estudios de Francia y en particular a todo el equipo, a Fanny Elliot, a Laurence Thiel, a Juliette Bro y a Sofía. Muy bien, entonces dicho todo esto, la agenda de hoy está dada por el inicio de la presentación de la escuela. Nosotros como Universidad ISALUD hemos estado en contacto con la Escuela de Salud Pública de Harvard y con la Escuela de Salud de la Johns Hopkins. Entonces, para nosotros es muy importante conocer a la Escuela de Altos Estudios de Salud Pública de Francia y conocer su valor agregado, sus diferencias con respecto a otras escuelas a nivel global. Así que muy agradecidos y les cedo la palabra. Gracias.
¿A nosotros?
Sí.
Hola, hola Arturo, hola a todos. Me encantada. Me llamo Laurence T.O. Estoy la, ¿cómo se dice? Deputy Director. This is why I speak sometimes in Spanish and English when I can't find the words. So, Deputy Directora de Fanny Elliot en la Escuela de Salud Pública desde 20 años.
Bien.
Lo que pasa es que yo hablo un poco español, pero no estoy segura que puedo hacerlo todo. Entonces, quizás si está bien para ti, Arturo, voy a intentar en español. Y cuando no encuentro las palabras, lo que pasa es que la escritura es un poco extraña. ¿Qué prefieres?
Nosotros tenemos seteado el Zoom para que hables en inglés y nos
Bueno,
traduce
ya-
automáticamente en español a nosotros. Entonces quizás
acuerdo.
sería más operativo a los fines nuestros del Zoom y del YouTube que hables en inglés.
Sí.
Y
Ok.
despacio, porque el algoritmo es un poco lento.
Sí. All right. So I will do it in English now. I
Yeah.
feel much more comfortable. And please don't hesitate to tell me in case something is wrong in the translation. I will be happy to do it, say it
No
again.
está traduciendo.
Okay?
Sí.
So
Danos un minuto. Un minuto.
Sí. Yes. No problem.
A ver si podemos probar ahora.
See, and we just a question before we start, because we sent you the presentation. Who is sending the presentation? Are you doing it?
No la estamos pasando la presentación. Necesitas que... ustedes pueden compartir la pantalla. Pueden compartir la presentación con Juliette.
Yes, Juliette is looking. We thought it would come from Argentina, but it's okay. We can find it.
Bueno, muy agradecidos.
In which language then? We use the one in English, right?
Sí, sí.
Yes. Okay.
Vos, Ruth, te podés conectar con el...
Is that okay, Arturo? Can you see the presentation?
Sí, se puede
Yeah?
ver
Okay.
la presentación en inglés.
Okay.
Después, en todo caso, para la audiencia, les vamos a pasar las dos presentaciones en español.
So I wait for your signal. You tell me when you're ready.
Ok, estamos listos.
Vamos?
Sí.
Well, thank you very much for giving us this nice opportunity of introducing the School of Public Health, the French School of Public Health, which is École des Hautes Études en Santé Publique. As I said, I am the Deputy Director of the International Relations, Deputy to Fanny Elliott. And I will present you the activities of our schools for about 30 minutes, right? So concerning the school, first of all, I suggest we start with a general overview, and then we'll go to see each of the missions that we have, which are very classical missions for a School of Public Health. And starting with that, I just give you some hints about geography as introduction. So we are not in Paris, although we are the National School of Public Health. We are based in Rennes, which is the capital city of a province, which is the province of Brittany, Western. It's quite close from Paris. It's between 1 hour and a half and 2 hours of train. So quite easy. When you come, you will see it's very easy to reach our school. And we also have a campus in Paris, a very small campus, but main of our campus is in Rennes, or Rennes.
Okay.
Here you have a few pictures of the campus in Paris that we are now moving. So, and we are, it's changing right now. This year we are going to move some of the training courses that used to be in Paris. They're moving back to Rennes.
Okay.
I just want to check something. I will come back to this into details, but our school in France has something very special compared to quite a few models you may have in other countries. And that's why we say it's quite unique in France and Europe, in the sense that, first of all, we have what we call a double connection to ministries. I will come back to that when talking about the history of our school. But now, today, we are both connected to, when I say connected, I can't find the right word in English. As in Spanish, we might talk about tutoria. We are under or connected to both the Ministry of Higher Education and the Ministry of Health. So it means, on one hand, we are an institution that delivers academic trainings and research, and also we are a public health education public service school for public servants. So we can come back to this into some details in terms of history, that the start of the school was just after the Second World War and started as a service of the Ministry of Health to train some medical doctors in hygiene and the implementation of public health programs. And it was based in Paris. And then in 1960-62, we had a strong and important law of decentralization, and many schools for public servants were decentralized. And the one of public health moved to Rennes. But we also, in France, we have many schools for civil servants, which are specialized. There is one for the very high civil servants for the highest levels, which is called the School of Administration, National School of Administration, where our president, Mr. Macron, was, and many others, also like the previous president and ministers, they came through this school. But we also have very specialized schools for different type of civil servants. For instance, for judges or for inspectors in education. There are like 40 schools for civil servants. So we are the ones specialized in public health. So coming back to the history, we moved to the campus of Rennes in this decentralization process. And then has been a strong change again in 2004 with the new law that moved our status from this type of school, keeping the same mission, but also adding the status of higher education, kind of like a university. And that the change was that we, from that time, were able to provide academic program, master courses. I think in this sense that we are quite close from ISALUD. We can come back to that a bit later. And from that time, we were able to provide master courses, including a Master of Public Health. I will come back to that. And now, from last year, although we are independent from the university, we joined kind of a big consortium around the University of Rennes. But we are still independent from them. Ça passe pas. I try to move on, but it doesn't. So coming back again to the missions, which are defined in the law, we have 4 of them. And of course, you understood that the one we had from history is still there. Then was added the second of academic training. So where we start, include in our trainings, we start from the master level. We don't have bachelor, it's a choice we have made so far. So we start at master level and was going to say doctoral and PhD. Then we have the research, of course, with higher education, the development of research is very important, and international relations. And sorry, I have some, we have just, yeah, you have a question?
Yeah. Sí, déjame hacerte una pregunta. Cuando vos dijiste hace un poquito que la escuela se integró a un consorcio más amplio con una universidad,
Sí.
es la Universidad de Rennes. ¿Podés ampliar un poco ese punto?
What would you like to know?
Cuando vos dijiste que recientemente la Escuela de Salud Pública se integró con la universidad. ¿Esa universidad es la Universidad de Rennes?
Yes. Yes, it's the University of Rennes, yes. But it's not a complete integration. There is kind of a legal nuance. It means we are part of a consortium. We are part of the decision boards, but we still have our legal status, which is independent. So coming back to some figures, just to give you an idea of the activities on the side of our schools, which is independent. I said we are connected to the ministries, but we have an independent status, not connected to any, not dependent from any university. We count 1,100 students. But I will come back to students, because students for us is two different types of realities, of profiles of students. We have really many continuing education programs, like you do have, I think, for people who are working and for trainings. I will come back to that. We concentrated the number of worldwide partners in the world. We used to have more, but we try to reduce in having more active partners. So now we have 15 of them. And in terms of professors, we have certain permanent professors. They are around 90, but for many programs, we also use external professors. And those external professors, they are around 700 lecturers, which are, most of the time, they are professionals who have an activity of trainer at the same time. Okay, now in terms of organization, we have 4 departments that show you the fields of activity, education, and research of our school. So they are quite wide. There is one in human and social sciences, covering health policy, and also health determinants, and behavior. We've got the Institute of Management, and maybe management of healthcare institution and management of health system. And the professor who will come after, Nicolas Sirvin, he is from this department. Then we have the Department of Sciences in Environmental Health, and the 4th one in Quantitative Methods and Public Health, so epidemiology, biostatistics. All our teachers, permanent teachers, are connected to one of these 4 departments. Just to give you an idea, we also have, like now, international and in national higher education institutions, we are also committed into a certain number of accreditations and labels. So there is one about the welcoming of international students, bienvenidos en Francia. There is one in terms of sustainable development in research and quality of trainings, Calliope, which is a very important one also for continuous and professional education. So now if we go back to to go deeper, let's make a focus on the training of civil servants. It is something that might interest the people here online now, as it comes to management of health education, of health institutions. So here are the training we offer for civil servants. So you have two columns because this corresponds to two types of civil servants we have in France. Actually, we have three. We have civil servants for local authorities, which we don't have here. But then we have civil servants for hospitals and then state civil servants. And the trainings we offer for this type of civil servants, first of all, I have to explain to you how it works. You probably have the same in Argentina. It means that the people who are interested to become civil servant for one of these profession, they first take exams. It's national exams. We say competitive examinations. It's concours. So the Ministry of Health, depending on the need of the system, opens a certain number of places, and for each of these professions. Then those who are interested and have the profile, they take the exam, and once they are selected, it's very, very selective, by the way. Once they are selected, then they start becoming a civil servant as an apprentice, as a trainee. So they start to be paid at that time, but they are also trainees. Okay? So here are all the professions for which the school organizes the training once they have been selected. Okay? So let's have a look. You have these on the left, those trainings for hospitals. So you have different levels and different types of professions in terms of director for hospitals. The second ones are also directors, but for another type, either for small hospitals or social and healthcare, social care, institutions. For elderly, for instance, or for handicapped persons. Then we have the nursing administration program, so the head of all the nursing care in a hospital. And we also have, at a lower level, let's say in the hierarchy, the administrators. And we also have professional hospital engineers. Then there are also other professions for state civil services, which are inspectors mainly. So they are not working in healthcare institutions, but working for the ministry, but at different levels, either local in the regions or at the central level. And they work as inspectors, for instance, in what we call health and social affairs, medical inspectors. We also have pharmacists, school physicians, medical doctors, and also engineers related to environmental health. And beside that, we also organize these distance learning courses for people who want to get prepared to take the entrance exams before entering the school, to get prepared for these examinations. So to give you an idea, here is the length of these trainings for civil servants. So you see it's most of the time between 12 and 24 months. And something else I would like to tell is that this training is kind of half between training courses at school and placements or internships. So the way half-half was organized has been changed recently. It used to be in 2 or 3 moments here in our school, and then we are having it in different ways. Is it okay on your side, Arturo, or do you need to ask questions?
Sí, sí, te estamos siguiendo con las exposiciones. Está todo perfecto.
So here comes now the moment to talk about the second mission, which is the higher education training programs. Where now, since I showed you that this started in 2008, and now we are offering a certain number of master courses. So the first one we mention here is the one totally taught in English, which is the Master of Public Health on a 2-year program. And for international students, 90% of them are from all over the world, except France. There is also the European Master Program, which is a pathway among 7 partners in Europe, where for 2 years also, where the students, they choose their pathway among those partners, and by the end of the program, they get 2 national diplomas. Then the other master courses taught in French are almost all of them, I would say, are co-delivered with other universities. It means it's a partnership with University of Rennes or University of Paris and other schools. It's more and more happening, having these co-delivering of trainings. Beside that, there are other type of master courses which are called postmasters, and what we call here it's institutional specific diplomas. Is would be called like un título propio, un título universitario propio. And of course, there is also for the PhD, we are organizing and coordinating a network for doctoral studies. So here on the right, you've got the number of students. I forgot to mention something before, so I will come back to that. I said we had more than 1,000 students. And here you see that among them, we have between 350 and 500, depending on the years, being as master students. Then we have the PhD students. And of course, the others are students which are into the civil servant training programs.
Una pregunta.
Yes.
¿Esos estudiantes de la administración civil necesitan su título para ingresar a los hospitales y a la administración pública francesa? ¿Es así?
Yes. So you talk about título. It's not a diploma. No es un título nacional. It's not a national degree, but they must succeed. They have an exam, and once they have succeeded the training, then they go for a job position.
Okay.
They have what automatically they have to look for which place they go. They meet where they have places, but once they enter the training program, and if they succeed the course, if they complete the examination, they are 100% sure to have a place. Okay?
Sí.
Just coming back to the lifelong learning programs, that's something very important in our school as well. We have many programs for people who have already a position, and they come back for training sessions that may last from, some of them may last 2 or 3 days. But we have more and more longer training programs which are built as what we call certificates. It's called school certificates for a few weeks. And for instance, we may have some programs where you have 6 or 7 modules upon a year, having one of from 3 days to 5 days a week. And we have many professionals in our training programs, more and more, sometimes 7,000, 8,000 per year. And there is a catalog and training of these sessions. And beside that, we also have tailor-made programs for depending if sometimes there might be a reform in the public health or in the health system, and we are called for developing a special training to accompany this reform. Besides that, we also have...
Otra
Yes,
pregunta
sí.
puede ser, cuando vos decís tailor-made, ¿son cursos hechos a medida?
Yes, exactly. Exactly. A medida.
A medida según las instituciones que lo solicitan.
Yes, absolutely. It's also very important, and that has been developed a lot in the last years. I didn't mention that, but including in the continuous education, we include more and more distance learning, and also innovative way of teaching. So we have now a strong team of persons, we call them education engineer, and they bring support to the professors here for developing this type of training with, for instance, we have apprenticeship, something I didn't mention, but I should also focus on. It's something also strong in France is the fact that we can have master courses in apprenticeship. So all our French master courses moved to this model where the students spend, I can't tell you exactly now the percentage, the rate, but probably 2/3 of their time in kind of internship or practice place with an employer, and then 1/3 of the other time at school. So it's also something that we have changed in the last 2 years. So it's something quite interesting to know. And also for all distance learning, so we have this team called Bringing Support to the Academic Innovation. If we move now to the research, so the research activity, I think the best will be, we have, sorry, I look for something here. The areas we have here of research correspond to the different fields I've presented in the when I showed the departments. Our professors are linked to what we call the research team. It's called labelized and mixed research units, sorry. So all professors are linked to that, and Professor Sylvain, who will present soon, he's linked to one of these research units. Yeah, here they are. There are 2 main ones, but there are quite a few others which are satellites units where some professors are linked to. But here are the 2 main ones. So there is one in health environment, environmental health, let's say. And this one is called à Rennes, and deals with social and health inequalities, mobilization in public and media space, public actions. And among this, there is what we call, it's quite complicated. I don't know if I should go into details about that, but there is a label of research with INSERM, which is the medical research institution in France. And it's called Research on Health Services and Management. And that's to this team where Professor Sylvain is attached. There are quite a few also research chairs. The data is now 2 years old, so you see there are in economics and management of healthcare institution, other in environmental transition, management of health and health prospects. I mentioned when I presented the different training that the school organizes, there is also the Public Health Doctoral Network. This is very special because it's something that was launched when the school started its new status. And we were invited to be the coordinator of a network of doctoral schools. So it means that we have the role of coordinating the training program of students who are registered in different schools, doctoral schools, where they have a component of public health. So we organize the training for those students. There are also some contracts, PhD contracts for some of them. And we also some of our professors are also tutoring, supervising doctoral students. So this is something quite unusual in the French landscape and even international landscape. It's not only having doctoral schools, but this kind of network and coordination of the activities. And we organize meetings, international meetings, and mobility of the students in foreign laboratories. Now, if we go to the fourth mission and the fifth point of this presentation concerns the international relations. So this international, maybe it's more developed because it's the presentation we make in our department. So of course the international relations relates to the curriculum and some expertise also we may share with partners and strengthening partnerships. I will go directly to that. Concerning the curriculum, I mentioned to you that some of our programs are meant for international students, international public. This is the case of the MPH. It's taught in English. It's also based, you mentioned you had connection with Harvard and Johns Hopkins. When we developed this MPH, it was also developed on the same model than the American MPHs. In relation with the Council for Public Health Education in the United States. So we have different tracks, but it's a 2-year program with different tracks and corresponding to the fields, recommended by the Council for Public Health Education. Then you see Europe Hub Health, I already mentioned it, which is a European master which is funded by the European Commission, and we have grants for students, but we also have the chance to welcome visiting professors. And, ISALUD is a partner of this program. I didn't mention that previously, is an associated partner. And we had in the past 2 professors, visiting professors. There is Adolfo Rubinstein, you may know. He's been a visiting professor there. Adolfo Rubinstein.
Sí,
Sí.
le conocemos.
I don't remember, but he's another professor who was also in the same institution, CEES, in Buenos Aires, and another professor from Argentina. So we would be very happy to have other visiting professors in this program. Mm-hmm. And the PhD, as you see, there are also many international students.
Yo tengo una pregunta. A ver. Bueno, terminemos la presentación y vamos a las preguntas.
De acuerdo. Concerning the international cooperation, our school also has been involved in many projects of cooperation with, in the sense, what we call cooperation is strengthening, capacity building, strengthening the capacities of institutions, of schools. And for instance, one of these projects, not here on this slide, but we've been working with ISALUD in a European project with and Santiago Spadaforo. But there has been many other projects where we've been working with a school in Central Africa or in Algeria or Georgia. So that's where our professors are bringing support to the development of programs, training programs or research or expertise. Now, since last year now, all this activity has been transferred to a subsidiary, una filiale, a subsidiary of the school, which is called EHESP International, which is really focusing on these projects. And that's it. So that's it, and now we can have some time for the questions.
Muy bien. Aprovecho y te hago esta pregunta. Antes de hablar de las relaciones internacionales, había una diapositiva, una filmina, que decía algo de fortalecimiento de los laboratorios en el exterior. Antes que esta.
¿Antes?
Antes, una más antes. Ahí. Encourages International Mobility. Ahí, en la 27. In Foreign Laboratories. ¿Eso está conectado con lo siguiente? ¿Tiene alguna acción en particular?
I'm not sure I heard, because the translation is not good.
Ajá. En la última línea de la página 27 dice fortalecimiento de la movilidad internacional de los laboratorios en el exterior. Eso refiere a las escuelas de salud pública en el exterior, a las universidades, y qué acciones hicieron ustedes en esa línea.
Okay, so this sentence refers specifically to the network of PhD students or PhDs. So it means that all our PhD, there are 90, which are, the studies between around 3-4 years, and during their PhD, the doctoral students are invited to have international mobility. So we have, it means that here in France, they are connected to laboratories, and they spend 6 months or sometimes more in partner laboratory. So they have sometimes scholarships to help them to go there. Most of the time it's also based on the research projects on which they are working on. It's okay? Does it answer
Sí,
the question?
perfecto. ¿Y ustedes tienen líneas de financiamiento para países en desarrollo, para hacer actividades comunes?
When it happens in Europe, we may have some Erasmus grants, and then it's mainly the laboratories having their finance, because they finance mobility sometimes when the project plans some international collaboration. But I can't be more specific.
Ok. Bueno, paso a la pregunta.
¿Qué tal? Buenos días. Mi nombre es Alejandro Costa, soy vicerrector de Planeamiento y Desarrollo de la Universidad. Muchas gracias por este espacio de encuentro y por compartir la experiencia de la Escuela de Altos Estudios de Francia con nosotros. La pregunta es, con vistas de mediano y largo plazo, ¿qué perfiles profesionales nuevos dentro del sistema sanitario y qué temáticas innovadoras están planificando desarrollar oferta educativa?
I don't know if I'm the best person to answer these questions. The new profile we train in our school, and in terms of topics, I could say the one that comes to my mind. For instance, in terms of topics, there is one related to climate change and resilience and transition. Digital transition and climate transition related to the health system. This is something we are more and more solicited. There are also innovative training related to impact. Maybe you can mention that, or you could give some.
Yeah.
Professor Silva can
Medicine manager.
Okay.
Buenas, yo me voy a hablar en inglés. Yo entiendo un poquito español, pero me voy a hablar en inglés. The new things that we are trying to apply here, especially with regard to hospital directors, is to build education that is closer linked with research, and especially research on health services. One of the tension on the market of the labor market for hospital directors is that nowadays in France, medical doctors can become hospital directors. And medical doctors have a natural tendency to lean on research. So we are developing two new strategies, one with medical doctors, the other one with civil servants who are becoming hospital directors, and we are training them with the use of research in management, in economics, in sociology and everything, in order to improve their decision making. So one of the key of this school is to adapt to the change in who can become a hospital director. If I'm not mistaken, in Argentina, only medical doctors can be hospital directors. In France, it's only administrators, but now this thing is shifting towards medical doctors as directors.
Yes, it's something I forgot to mention. Thank you for emphasizing this. It's very important.
Muchas gracias por la respuesta conjunta. Una aclaración. En Argentina, la mayoría de los directores de los hospitales son médicos, pero se están dando casos donde hay directores de hospitales que tienen otros grados, como ser enfermeros con posgrados o también profesionales de ciencias económicas, por ejemplo, contadores. Y además, Argentina es un país de 46 millones de habitantes que tiene alta concentración en provincia de Buenos Aires y Capital Federal y 4 o 5 provincias de más de 1,5 millones de habitantes. Y cada provincia tiene normas propias sobre remuneraciones y jerarquías hospitalarias. Así que tendríamos que hacer todo un relevamiento sobre el tema. Era una aclaración. Bueno, voy a preguntar a la profesora Ruli Manovich si tenemos preguntas en el... Ok. No tenemos preguntas entonces en el YouTube, o sea que si les parece le agradecemos muchísimo a Lorenz todas sus presentaciones y sus aclaraciones.
Con mucho gusto.
Una pregunta más.
Una consulta sobre el financiamiento de la escuela. ¿Es completamente financiamiento estatal o también tiene otras fuentes de financiamiento más allá de las capacitaciones a demanda que puede establecer pedir una institución o los financiamientos externos por investigación? El alumnado, cuando va a formarse, ¿ya tiene pago a través del Estado su formación o el alumnado también tiene que hacer aportes? Y cuando hablo de alumnado, de los alumnos, estoy incluyendo a los alumnos de Francia y a los alumnos internacionales.
Okay. So I don't have the exact rate, but the largest part of the budget of the incomes of the school are from the Ministry of Health, mainly for the training, and that covers the training of the civil servants. So it means the civil servants, not only they do not pay their training, but they are paid during their training. You know, as a trainee, they are paid during this period. So we have this, and then there is also a smaller part from the Ministry of Higher Education covering a certain number of professors' positions. And then concerning the master course, another source of income from the school is the continuous education. Part of it is covered by the first of the continuous education, should be covered by the money given by the Ministry of Health, but only part. And then the rest of the continuous higher education is paid by the employer most of the time, sometimes by individuals, but most of the time by the employer. So this is a source of income, continuous education. And then concerning the master programs, in France, the French and European students pay very low fees for a master course. It's around 300, 500 euros. So there might be some higher fees for international students, but we are not in the model of, for instance, the United States or the United Kingdom, where we have very high levels. In France, it's not that high, and it's not a real source of funding. It's marginal.
Ok, ese arancel es de carácter mensual.
No he entendido, perdón.
Lo que-
Monthly, okay. No, no, okay, so mensual. The fees are annual.
Ajá. O sea que traducido para nosotros sería 500 euros por año en un Magister Course de 2 años.
I'm not sure. This is the amount when you say, I said it was in France for French and European, it is between three, I think it's 350 or let's say 400 per year for 1 year.
Ajá. Y esos son cursos que se dictan solo de maestría, que se dictan solo en francés o también en inglés.
This is for the French courses, yes, the courses in French. Then we have this, what we called, I didn't mention that, I can be more specific if you want to. What we call postmaster programs are a bit different. Postmaster programs are more for professionals, and they are organized different ways, like a week per month, so that people can still work and be trained at the same time. And most of the trainees are professionals, and their participation can be paid by the employer. And in that case, I don't remember now, but I think the fees can be 5,000 euros a year for these master courses. So for these courses, this can be economical model. But these are specific. These are not what we call national master degree. They are título propio de máster.
Bien, muchas gracias.
Con gusto.
Bueno, si les parece entonces podríamos pasar a la presentación del profesor doctor Nicolás Serven. Y muy agradecidos nuevamente por toda la ayuda que nos están dando. Nosotros hacia fin de año estaremos en contacto de vuelta a ver si podemos retomar la alternativa de pasar un día por la escuela en una visita que llamamos de módulo internacional. Déjenme ampliarles que la universidad ya tiene 35 módulos internacionales realizados, varios de ellos a España o Italia, y también a la Pan American Health Organization, a la OPS en Washington y a distintos países de Centroamérica. Así que para la universidad es importante seguir sosteniendo las visitas académicas anuales a otros sistemas de salud, y muy agradecidos. Después les vamos a pasar a ustedes el transcript de todo lo que hemos conversado hoy. No, si podemos hacer una pregunta más, Lorenz, Juliet. La pregunta dice, es de una alumna de segundo año de maestría. Quería consultar si, al igual que lo que se vio en nuestro viaje anterior a Italia, se está viendo en muchos países en la época post-pandemia, que hay una crisis en los recursos humanos en salud. Por ejemplo, la falta de postulantes a las áreas de cuidados críticos, terapia intensiva y pediatría, que no son elegidas por los profesionales recién graduados de las universidades de salud de Francia. de medicina, ¿no?
I'm not a specialist of this type of questions, professor in health, human resources would be more in the situation. We can hear that there are some crises, there are crises in human resources in health system, but I can't be more specific.
Since the COVID situation, in order to face the shrinking numbers of hospital workers, not only the doctors, but also the staff there, the government decided to increase the wages in the hospital sector. Since then, the problems have been contained, but still there is this issue that the public sector especially is less attractive than the private sector.
Mm-hmm. Ok. Entonces hay un diferencial de precios entre el sector público y el sector privado que afecta el ingreso al sector. Eso es lo que nos transmite.
The price difference is not that much, but there is business model for the private sector that is very specific and allows the sector to provide better wages. This was part of my presentation. I can explain, I was about to explain how does the French hospital system work between private and public sector.
Perfecto. Entonces esperamos tu presentación.
Muy bien, muchas gracias. I have to leave you at 3 because I have another presentation to give. So we'll just try and speak for 15 to 20 minutes and then maybe leave time for questions. So I will go straight to the point. If that's okay with you?
Perfecto.
The first idea is to show you how efficient the French system is in comparison to other systems. Efficiency is measured as the gains in life expectancy you get with regard to the amount of healthcare expenditures you have as a share of GDP. And as you can see, between 1980 and today, basically all of the European healthcare systems have been converging towards what seems to be like one point of efficiency. So all the systems were very different, eventually came out very similar in terms of efficiency. The only one that is still very inefficient, very different from us, is the United States model. And of course, we know what. We know why. So my point is to just show you that France keeps up with other developed healthcare systems. And now my point will be why. What were the big reforms that France has undergone to maintain its level of efficiency? Well, this graph gives you the level of healthcare expenditures in GDP since the 1950s to today. And as you can see, it has, in most countries in the world, expanded quite a lot. From 2 to 3% in the 1950s to something like 9 or 10% today of GDP. So multiplied by 3 in 70 years. Now, what's important to notice is that what essentially is made of healthcare expenditure is hospital care. And hospital care has undergone two regimes. The first one, from 1950 to 1983, was like a rapid expansion of healthcare expenditures of the hospital system. And after that date, 1983, which is date of a very strong economic crisis in France because of too much debt of the government, after that, the regime has become much flatter. So the question is, what happened to hospitals in 1993? So before that, the hospitals were paid as a global budget. Basically, every year, the government or the social security would pay for hospital care as much as requested. And this could have led us to some medical arms race, which basically is an increase in healthcare expenditures, uncontrolled. After 1983, the global budget was the same, but the government decided that the budget will not increase from one year to the other. The consequence of that was that hospitals started to produce less healthcare, less activity, because no incentive were available for more production of healthcare. So this could lead to a health issue, public health issue. So we needed to find a solution to increase activity in the hospital and give them some incentives to produce more. This was true for public and private hospitals. And in 2005, what happened was the implementation of DRG. DRGs are the prospective payment at the hospital, like case-based payments. DRGs.
DRG.
Yeah.
Diagnosis-related?
Diagnosis-related groups. Yeah. So I understand that it's also case-based payments, which some hospitals in Argentina may be experimenting. It's prospective payment.
Sí.
So you understand that the idea is yardstick competition.
Sí.
In 2005, this reform helped change a lot of things in France. And these are the consequences that we can see. Is that first consequence was the diminution of the length of stay in the hospital. In medicine, in surgery, everywhere. The second good consequence was that mortality also diminished. So basically, we were very happy that this reform of diagnostic-related groups provided an increase in quality. However, not all quality was reducing. For instance, readmission rates increased a lot. So we understand that hospitals shortened the length of stay, but patients may have got out of hospital in worse health, so they had to come back as a readmission. And one of the reasons is really easy to understand is because quality is expensive. So if you put hospitals in competition, on price competition, then they have the incentive to reduce the level of quality, especially seen as readmission. So the first conclusion of this reform is that not all the elements of quality increased. So we have one question, which is how to increase quality in the healthcare system. And one possibility is to pay for quality, what we can call pay for performance. Oh, sorry, not pay full performance, but pay for performance. Pay for performance. Oh my God.
Pagar para performancia. ¿Cómo se dice performancia? ¿Cómo se dice?
P4P, pay for performance. All right. Well, okay, you got it. But the problem, if you pay for performance, may lead to patient selection. Basically, hospitals will get the incentive to increase the share of good patients to get more money out of that. And the money spent in pay for performance is always not sufficient. So because it is costly, another solution has been proposed, and let me present you this position. It's a website or an app you can add on your telephone. And this website helps you compare hospitals in terms of quality. It's called QualiScope, and it provides doctors, patients, citizens, everyone in the community can access this website, even professionals within hospitals, so they can compare hospitals in terms of various index of quality. For instance, readmission rate, mortality rates, certification, or patient satisfaction. The idea behind that is a public policy to empower the patient. So the patient and its agent, who is the doctor, medical doctor, can help choose the best hospital for a hip replacement or for any type of surgery or whatever. So you can choose where you want to go, and this is supposed to increase competition. But if you look carefully at the results you get from this website, this is what you get. So the first measure I'm using here is the rate of satisfaction. So patient satisfaction rates between 2015 and today has been increasing, which is a good thing. But if you look carefully, the public sector has always lower levels of satisfaction than the private sector. And P&L means privé non lucratif, which is private sector without making any benefits. So basically, this is true for patient satisfaction, but look as well, if you're looking at the rate of readmission, the public sector is not as good as the private sector. And The same is true for mortality. Again, the private sector is always better in terms of quality than the public sector. So the question is, why is the private sector always better than the public sector in terms of quality? And this is something that is a paradox. We don't understand, because quality is expensive and the private sector seems to manage high levels of quality, and at the same time it makes profits, whereas the public sector doesn't make any profit and has lower levels of quality. So we don't understand this paradox. The public sector, in theory, should be better in terms of quality. So what are the two assumptions to explain this paradox? Well, the first assumption is that the private sector selects its patients. So patient selection is the business model of the private sector. Another assumption, very often displayed in the media, is that the public sector is very bad at management. We are the worst managers ever. And well, this could be true. If you look at the science of management, this is what has been published last year by a colleague of us, Luigi Claudio Lucifora from Italy, and he's been using data from the World Management Survey from 2009, and you can clearly see the levels of good management in hospitals, whether public or private hospitals. So the US has the highest level of management with the UK. And if you look at France, France has the lowest level of management. And without any surprise, in almost all the countries, the level of management is better in the private sector than it is in the public sector. So the first idea is to say, well, it's very likely that hospitals, private hospitals, are better managers. And if you look at the evidence, this is evidence from the United Kingdom, for instance, there is a clear correlation between the level of quality, 1, 2, 3, 4, or 5, and the average management score, meaning that hospitals with better management always have better quality. So there is a test that has been done in Chile, and you must know about that, probably. Your neighbor, Chile, had a reform in 2003 where hospital directors, where doctors were allowed to have new hospital directors coming from the private sector. And when those people from the private sector became hospital directors, and we checked that they had training in management. And suddenly, when Chile has new hospital directors coming from the private sector, trained in management, then the level of mortality started to diminish in this country. So now it's not just a correlation, it also is causality that training hospital directors to management may improve quality. However, what seems to be true is that 36% is the share of quality that management explains. In other words, yes, management explains quality, but only 1/3 of it. So 2/3 of quality are not explained by management. So what could be the other reason? And of course, the other reason is sample selection. And this is the business model of the private sector in France. If you take the example of a young man coming to a hospital with a broken knee and needs a knee replacement, if the young man has no comorbidities, is in good health, does sport, doesn't smoke or drink, then the private sector would be very happy to have him, because a young standard patient is less costly to handle, and also a young patient has less chances to develop a bad health. So as a result, if you select your patients, your quality score increase without any effort. However, when the patient is too old and weak and sick, for instance, an old lady coming to the private sector, then the doctor can say, sorry, because we don't have the full medical possibility to treat you, we have to send you to a place where they are able to treat your case and handle all the possible poor consequences of an operation. And this is the public sector. So basically in France, bad patients are sent to the public sector, where they are more costly and where the level of quality diminish without any effort. Even if in the public sector, the doctors will produce much more effort than in the private sector, whatever they do, the level of the score of quality remains low. So this is how the system works, and you can clearly see that the DRG, the Diagnostic Related Group payment system, clearly would give the same amount of money for a knee replacement for the public or the private sector. Of course, the price of the private sector is a bit lower than the public sector, but the differences do not compensate for the business model in the private sector. So what is now the next step in the change in the payment system in France is what is called risk adjustment. The idea is to use all the data from the state or the social security or the healthcare system to predict the risk of a patient and its cost. And for each patient to be paid at its real cost, this will reduce the incentive for sample selection in the private sector. So far, this just requires a good software, if you want a good program, a good software program to calculate the cost for its patients. It's underway, but it's not finished. So this is the next big thing that is happening in France. And I shall stop here, and maybe we can have some time for questions. Thank you very much. Muchas gracias.
Bien. Por ahí te hago una primera pregunta y después te presento a la otra gente aquí en la sala. La primera pregunta es, en esto que nos comentaste recién, vos decís que la introducción de risk adjustment, de ajuste por riesgo, permite calificar mejor a los pacientes para hacer el análisis de tipo prospectivo y de cómo calificar los pacientes que se atienden, tanto en el sector público como en el privado. ¿Eso es así?
Yes, because in France, the information system about payments is generalized for all patients, including hospital care and ambulatory care. We are able to compute since birth till death all the healthcare expenditures for each patient. And the idea is, thanks to these data, compute the individual risk for adjustments for each patient over his life. And this will give different prices, of course, and for the private sector and the public sector. For the moment, let me underline that the private sector has the same amount of money than the private sector for the public sector for the same operation. Only the public sector gets a lump sum of, I don't know, something like 5 to 10% additional cost. But this is not enough in comparison to the money that is necessary for running the public sector.
Bien. Mi última pregunta es, la introducción del ajuste por riesgo después va acompañada por algún tipo de incentivos para el sector público, incentivos monetarios, o por ahora no?
Por ahora no.
Ok, les presento al secretario de Ciencia y Técnica, Claudio Ortiz.
Hola, muy buenos días.
Buenas.
Muy interesante tu exposición, Nicolás. Acá
Gracias.
desde YouTube, Franco Caputo agradece tu exposición, dice que es muy interesante. Quería hacer algunos comentarios. Es muy interesante lo que haber verificado que solo 1/3 de los resultados de calidad están relacionados a las aptitudes de los gerentes de las organizaciones, y esta preocupación por los otros 2/3, digamos, y esta solución que encuentra Francia del ajuste por riesgos. Te quería preguntar si han estudiado cuánto impacta los diferentes regímenes salariales del sector público y el sector privado y las diferentes formas de ejecutar el presupuesto en ambos sectores, si eso también no habría que modificarlo para permitirle al sector público tener mayor posibilidades de gestión. No sé si entendiste mi pregunta.
Sí, muchas gracias. The answer is in the literature. I didn't have enough time to show, but basically, here it is. Basically, if what we tried was to measure the amount of quality you would get if the public sector would get the patients from the private sector, and if the private sector would get the patients from the public sector. Like if two sectors would switch their patients. And the answer is there would be no difference. So what I read from that is that what really matters between the public and the private doesn't seem to be work conditions, but definitely the patients. And because it's the patients that change everything, of course, work conditions depend on the patients. If you have the worst patients, definitely the work conditions will be bad. If you have best patients, then you have good money and it's easy to work with. So what seems to be said in the literature is that it's definitely sample selection of the patient that matters, and not and all the rest comes after.
Perfecto. Entiendo entonces que el tema central es la selección de pacientes. Ustedes lo tienen bien estudiado. Al pagar por grupo relacionado de diagnóstico pueden estudiar las diferencias del case mix de cada uno de los establecimientos públicos y privados, y ese es la consecuencia más importante con el tema de la calidad. Lo entiendo de esa manera.
Sí, eso es.
Perfecto. Quería preguntarte también, no sé si perdí un poco en la charla, entendí que hay un lugar, una página, un lugar público donde se publica la calidad de los diferentes efectores de salud, que está, digamos, disponible para la población en general. Y esto quería preguntarte, ¿le permite a los pacientes elegir en este momento? ¿El paciente podría elegir por calidad algún efector frente a otro al poder mirar los datos en esa página?
Sí, you can go to this web page. It's called HAS and Qualiscope. And if you just type that on the internet, you get it. And even from Argentina, you could select a hospital in France, and you can compare between two hospitals in France for the same from the same issue. Yeah, it's free, and it's available to everyone. The patients, the doctors, the professionals, the hospital directors, and there's like 20 indicators of quality there.
Perfecto, gracias.
Quería ampliar un segundo sobre este punto. Lo que nos estás diciendo es que hay algunas páginas web donde se puede entrar gratuitamente, incluso desde Argentina, para analizar los desempeños, performance relativos de calidad y de precios de dos hospitales franceses.
Sí.
Ajá. Ok. Eso nos interesa mucho porque el tema calidad para nosotros es un tema clave en nuestros cursos de magíster y en los cursos de grado también. Así que quizás, bueno, haremos algún chequeos al respecto y por ahí te volvemos a consultar a través del mail. Te vuelvo a pasar con Claudio.
Nicolás, quería hacerte una consulta.
Sí.
Esos 20 indicadores de calidad, ¿se incluye el reporte de eventos adversos relacionados a seguridad de pacientes? ¿O
Sí.
Sí, incluye el reporte de eventos adversos.
Sí.
Perfecto.
Bueno, eso nos interesa mucho, así que probablemente haremos algún avance y por ahí te volvemos a consultar. No sé si en el YouTube tenemos alguna pregunta. Bueno, entonces te agradecemos, Nicolás, porque estamos sobre la hora de tu próxima conferencia sobre China, hasta donde entendimos, y agradecemos mucho tu colaboración. Bien.
Muchas gracias. Adiós. A la próxima, amigos.
Hasta la próxima vez. Muchas gracias. Yo quería aprovechar que quedó Juliette. Bueno, Juliette, en tu nombre quiero agradecerle a Lorenz Thiel, a Fanny Elliott, a ti y a Sofía por toda esta gestión que ha sido muy provechosa. Nosotros lo que vamos a hacer es tomar el transcript de toda la conferencia y reenviárselos a ustedes, y vamos a habilitar los PowerPoint en inglés y en español a través de un link en nuestro canal de YouTube.
Okay.
Y en todo caso seguiremos en contacto por mail para ver si podemos seguir avanzando con la posibilidad de la visita del 2025 de mayo, segunda quincena de mayo de 2025. Así que bueno, nuevamente muy agradecidos por toda la ayuda y la colaboración. Les vamos a mandar algunos de los materiales en español que tenemos escritos y nuestro dossier internacional, y vamos a seguir en contacto con todo el equipo. Por el otro lado, a través de acá, quiero agradecer a todos los que escucharon por YouTube y a los alumnos Silvia Bastón y Franco Caputo, que hicieron preguntas en la presentación. Así que de nuestra parte, muchas gracias, y vamos a completar ahora, en este momento, el cierre de la transmisión. Muchas gracias, Juliet. Thank you.
Thank you so much. Bye.
Bye bye.
Bye.